Okay, good afternoon, everyone. Dear colleagues, it is my pleasure to welcome everyone to the third day of online seminar series about addiction medicine for general practitioners. I am Dr. Evelyn Wijaya, a research assistant of Psychiatrist Department of Atmajaya University. I will be the host for today's session. We'd like to extend a special welcome to our guest of honor, Prof. Dr. Arnt Schellekens, PhD, who will be speaking today. Dr. Eva Suryani, psychiatrist, as a committee chairman of this seminar, and Atmajaya Collaboration, Radboud University Medical Center, and Nijmegen Institute of Scientist Practitioners of Addiction, who support this event. We are so glad to have you all today to learn together about the addiction medicine, which specifically will discuss about comorbidity, pain, and opioids. Today's agenda will be guest lecture from Prof. Arnt and discussion session, followed by closing remarks from Dr. Eva Suryani. For information for this event, so experts lecture will be presented in 60 minutes and will be followed by 45 minutes discussion. Participants could ask questions in the chat room, or you can raise your hand if you want to ask Prof. Arnt directly. And participants could also see the online seminar through YouTube channel FKIKUAG. Okay, for how to get e-certificate, I will remind you again that e-certificates are only given to participants who has failed the registration and pretest before each session, and also post-test with pass limit value 80, and it can be repeated if you haven't reached the pass limit value. The post-test link will be given at the end of this event, and the link will be closed at midnight 12 a.m. West Indonesian time each day. Okay, before we enter the main agenda, let's have some poll questions. If you could see the question on your screen, please choose and click one answer of each question. Okay, here's the results from our audience. So, 33 participants have ever given their patient a prescription for opioids, and there's no patients of them that have addicted to that opioids. Okay, next I would like to invite Dr. Durotol Ikrima and Prof. Arnt as our guest speaker, and Dr. Durotol Ikrima as a moderator for today's session to read the CV of our guest speaker and lead the session. Thank you.
Thank you, Dr. Evelyn. So we know that in the effective addiction treatment, comorbidities, it should be one of our considerations. So today we will specifically discuss about pain and opioid. What if our patient has a chronic pain and then is it wise to prescribe opioid right away? And what should we ensure when switching the pain medication and how to prevent them from addiction? So we should ask directly to our expert, Professor Dr. Arnt Schellekens, PhD, is a professor in psychiatry and addiction in Radboud University Medical Center. He is also a researcher in Donder's Institute for Brain, Cognition, and Behavior. He also became scientific director of the Nijmegen Institute for Scientists Practitioners in Addiction. And his expertise is also in substance use disorder, comorbidity. So we choose the right expert. He made a collaboration with ICASA, International Collaboration on ADHD and Substance Use Disorder, to study neural mechanism and genetic of reward processing and cognitive control in patients with ADHD and substance use disorder. He also had some working experience in Indonesia. Yeah, maybe Prof. Dr. Arnt Schellekens, PhD, the time is yours. Wow, good morning, good afternoon.
Good afternoon, all of you.
Yes, I saw that you use batik, right?
Yeah. Yes. That is a gift that I got a couple of years ago when traveling to Indonesia and providing lectures in real life. I mean, this is also real life these days, but in fact, it's far better to meet in person than on a screen, of course. So, then it's nicer to give a lecture. It's nicer to have interaction with all of you, with young students, with colleagues, and discuss more in detail sometimes. If you meet in person, it's easier to exchange information about cases or IDs or whatsoever. So, of course, this is how we have to do it these days. That's what we have to deal with. So.
Thank you.
It is.
So maybe you could share a little bit story how your working experience when you were in Indonesia, and also your son was born in Indonesia, right?
Yeah, my youngest son is called Indra, and he was born in Bandung, and he's already 9 years old. So it's a big boy now. It's 9 years ago. So. Yeah.
Good to hear that.
Good memories. Good memories.
All right. Yes, I have seen your presentation.
Yeah. So, shall I start?
Yes.
Good. I will. So, today, opiates. And I think maybe most of you know opiate use disorder as a condition of like heroin use, heroin misuse, heroin addiction. And yeah, that's of course an illicit drug. So you can only buy it in an illegal market. And yeah, sometimes, and I think until about 20 years ago, that was really marketed. We thought, some people still think, that opiates that we prescribe are not addictive. And I think around 2000, the pharmaceutical companies were actually telling us that. They were telling, well, heroin is dangerous, but the opiates that you prescribe as a doctor, there's no danger, don't worry, they are not addictive, there's no problem at all. You can safely prescribe them to your patients. And as a result, of course, yeah, doctors started prescribing it. And the important thing is that opiates are excellent painkillers. So they work. They work fantastically. If somebody is in pain, you prescribe morphine, yeah, these opiates will provide proper analgesia. So yeah, if you have a medication that is very, very effective, more effective than paracetamol in certain pain conditions, and you have a medication that you are told is very safe, I mean, what do you do as a doctor? You start prescribing it, right? So that's where this story about prescription opiates started, and that's somewhere around like 2000. And I think by now I don't know how much attention there has been in Indonesia to this topic, but you might be aware that in the United States, there is not only a political crisis and a COVID crisis and maybe also a bit of a financial issue, but there's also an opiate crisis. And some epidemiologists describe that as a syndemic. So there is an epidemic of the COVID infections, but there is also this epidemic of increasing opiate use combined with people dying from overdose of opiates. And those things go together, and they sort of strengthen one another, because you get like the COVID epidemic hits vulnerable people harder than more resilient people, and the more vulnerable people are also hit harder by this opiate crisis. So these different things then go together and strengthen one another, with the most vulnerable people, as always, being the ones that are hit most. So I think, yeah, it's important to pay attention to this topic, and that's why we chose to put it on the agenda today. There are many more important topics, of course, especially related to addiction. You could look at many comorbidities like depression, anxiety, ADHD. You could look at other physical conditions like HIV, hepatitis, neurological complications, and so forth. So yeah, this kind of lectures could build a month if you want, but yeah, that would be quite a lot of lectures. So we decided to put this one on the agenda, and also because it's a timely topic, at least worldwide. So I will talk you through this a bit. So I'll try to go to the next slide. Yeah, so my idea was to share with you a bit about the epidemiology first. And I'm sorry for not having detailed information about the epidemiology in Indonesia, but I do have data on, of course, the United States situation, which is sort of very alarming still. And in addition, some data from Europe, more detailed data from Europe, and from my own country, from the Netherlands, which we published last year. Then I would like to continue with what you might also be aware of. There seems to be a link between psychiatric symptoms, mainly mood and anxiety and opiate use. And how can we understand that link? How does that work? And then finally, I also want to end up with a bit of hope. So the epidemiology doesn't always make you happy. The relationship with psychiatric symptoms does not always make you happy. But over the past couple of years, we've been working on a new treatment for this group of patients. And that seems to work pretty well. So I also would like to share some of the data of that study, which is, I have to admit, not published yet. So there are now 2 papers that have been submitted, and we are waiting for, I hope, a positive evaluation, of course. So the epidemiology. To start with, the alarming situation in the United States. These kind of figures are impressive, right? So people dying from an overdose in 1 year exceed 60,000. I mean, that's a lot. And that's preventable deaths. And we are pretty much impressed by people dying in Vietnam, people dying of HIV/AIDS when it was on its top, in the United States at least. And this opiate-related mortality exceeds that. So where people were pretty much worried about AIDS in the 90s in the United States, about the Vietnam War somewhat earlier, people were sometimes not that much bothered about opiate-related deaths because they thought, well, that is something for poor addicts with a weak character, as we discussed on the first day. And this picture changed only when this epidemic of opiate overdoses shifted from the Afro-Americans, and it's really not nice to say, but it's true. So when the opiate mortality shifted from the Afro-Americans to the white Americans, only then attention rose from politics. So that's something that it makes you sad a bit. Huh? That it's always the same groups of people that are most vulnerable, and that is hit most hard by these kind of issues. So this is a bit more detailed, the situation in the United States. So as I told you, as of somewhere around 2000, this opiate story starts. And it starts because the pharmaceutical companies, as I said, were telling these opiates are excellent painkillers and they are not dangerous. So you can see the prescribed opiates, that's the blue line. It was not that much at that time, but it steadily increased and increased and increased and decreased. So that's the blue line. And what happened at the same time is that the overdose numbers, that is the line on top here, made a parallel increase. So that's impressive, right? And what is interesting that from a certain point in time, like somewhere around 2010, there was awareness of this problem, as I told you. So there was increasing awareness that these opiates were leading to mortality, addiction, all kinds of complications. And that's when the government started campaigns like trying to reduce opiate use. And what you see what happens then is that people shift from prescribed opiates to illegal opiates. So first heroin, and when the dealers saw that that was happening, they introduced the illegally manufactured opiates, which took over. And then you see that number of overdose deaths increases even further. So we are now in a situation, and this picture ends in 2017, but it goes on until today. We are now in the situation that the prescription opiates are going down a bit again, but the mortality is still increasing. And that is worrisome, because prescription opiates, you are sort of in control. But this illegal opiates, then it's out of your hands anymore. So where it started off with good intentions of helping people, this completely got out of control, and it's a bit messy, I can say. So if that many people die from opiate overdose in your country, that's really worrisome. So if we look at the situation in America in comparison with other parts of the world, there I don't have these nice pictures of more recent data. But what you can see here is that the US is on top, and then comes Europe. This is the global average, and then Africa, Southeast Asia, where you are, were kind of low until 2014 at least. And the question then is that because of a true difference, or has that also a relationship with registration? And we are now working on a paper trying to understand regional variation at a global level, but also within a country level. And we now found out that, your national statistics depend on what kind of definitions are used to count the number of opiate-related deaths, for example. Do you do post-mortem investigation on opiates? If you don't do it, you don't count it. So sometimes it's as easy as, if you don't see it, of course, then it's not there. But it might be there if you don't look at it. So it's a very important in research to look at the quality of the data. And I would be very much interested to take a closer look at the African and Southeast Asian situation, because if this is really true, then it is important for the Western world to learn from that situation. Why is it then different? And if it's because of the quality of the data, I mean, of course, then it's a completely different situation. But if these data are true, then how come that outside the Western world, the opiate use did not increase that much? So this is not mortality, this is simply opiate use, consumption. But that would be interesting. And if you take a closer look at Europe, there you also see all kinds of interesting differences. So you can see that on top are the United States and Canada, and somewhere in the middle are Germany and the UK, even though the UK over the past 5 years has become very problematic. I'll show you later on. And then we have the Netherlands and Spain, and France is on the lower level. So then again, you could ask, why these differences? What are the drivers of opiate use, and why does it differ between countries? And there are some ideas about it, which I will share with you later in the talk. So this is unpublished data that I told you about, taking a closer look in Europe. So here you see opiate use in daily defined dosages per 1 million. This should be 100,000 people. Sorry. So says 1 million, but it should be 100,000. And here you can see, as I told you, that the UK has become increasingly troublesome in terms of opiate use. So there is a large increase. And if you are a critical academic, you could say, well, why is the UK problematic? It could also mean that they have better analgesia for their patients. It might be that the other countries don't treat pain good enough. They don't prescribe opiates because they don't care about the pain in their patients. Could be another explanation. So why is this problematic? Well, that's the next picture. So here you see mortality. And then all of a sudden you realize, oh, well, it's not only good pain killing, but it's also people dying. And you can see here the United States graph with mortality over the past 10 years. Yeah, you already saw that. That was impressive. But look at Scotland. There is something going on. I mean, that mortality rate is over the mortality rates in the US. So that means that over the past years, per 100,000 inhabitants, 20 were dying every year of opiate overdose. That is huge. I mean, compare it to the US situation, it's 15 per 100,000. Compare it to the average European Union situation, that's 1.2. And that's 20-fold higher. That's really impressive. And the Netherlands are, I think, about around 0.7 or something. So there's huge differences between countries here. And look at the other high scorers. That's Ireland, Northern Ireland, England and Wales. So these British Isles are problematic. They are troublesome in concerning opiate-related mortality. That's a public health threat. And I don't know whether this has a relationship with them leaving the European Union, but at least this indicates that these British Isles are somewhat different from the rest of Europe in a way. What is also an interesting one is Estonia. So there was a peak in opiate mortality in Estonia somewhere 2012 to 13, and that decreased again. So if you take a closer look into the history of Estonia, you see that at a certain point there was illegally manufactured fentanyl coming from Russia into Estonia. And then you see that this consumption peaks, mortality peaks, and then they took measures getting this, closing this route through the Russian border, and then it went down again. So it's very important to take a close look what is driving the opiate use and the opiate-related mortality, because then you can take the right policy measures. And that's also what you see in the United States. So when you stop suddenly or reduce opiate prescriptions, people shift towards illegal opiates. So that policy response might not have helped that much. So it's very important to think about why do we see these pictures and what are the drivers behind it. And you can only find that out by asking people. So you have to do qualitative research there to get a better understanding of what is going on and then develop the adequate policy response. So that was also a reason for us to look into more detail into the situation in the Netherlands. And that is what you see here. So you see the different opiates over the past 20 years. And in the Netherlands, you can see that there is tramadol here on top, and that there has been an increase, but then it has been rather stable since, well, early 2012 maybe. But the real issue in the Netherlands is an increase in oxycodone use. So that's this line. And yeah, then again, you could say, well, if that's only an increase in use, it might mean that we have been improving our analgesia protocols. And in a way, that is true, because somewhere around here, like 2012, 2011, we started with taking pain as a vital sign in hospitals. That was obligated. So also in our psychiatry department in the hospital, we got the obligation to measure pain 3 times a day. So I refused because I knew these kind of data. So I thought, well, if we are going to do that, and in psychiatric patients that might have mental pain but not physical pain, we end up in trouble, because then all our depressed patients, we have to prescribe them in the end opiates, and that's going to make it worse. So the hospital allowed us to have an exception to this rule. But if all hospitals start measuring pain 3 times daily as an obligation, and then you have to treat it, because if you find pain, you cannot just say to your patient, okay, well, you have pain, enjoy it. That's not an option. So then you have to do something, and you start with paracetamol. Some cannot have NSAIDs because of kidney problems, for example. And then you get an increase in oxycodone use. And that could be a good thing, because you improve your brain treatment practices. But if you take a closer look on what has been happening in addiction care, as of 2008, so parallel with this increase, we see an increase in the number of patients coming to addiction care with addiction to prescription opiates. And that is interesting, because the heroin and methadone population has been stable over that period of time. So the increase is really driven by prescription opiates. And then here, look at the hospital admissions for opiate intoxication. You can see 2 lines. One line is rather stable, and that's the classical opiates: heroin, methadone, opium. But look at the other line, there's a steep increase, and that's the prescription opiates. So we saw that, this increase in oxycodone use is also paralleled by an increase in the number of people coming to the hospital with an overdose. And that is troublesome. And if you take a very close look, you see in time that this increase starts somewhere 2012. And then if you go to the left-hand panel, you see that parallels quite nicely with the increase in oxycodone use in time. So these things not accidentally fall together. And maybe what is most important is the mortality rate. I'll show you. So we would have expected that from 2012, there might also have been an increase in mortality. But in fact, we don't. So the mortality rate, you can see 2 lines. The line that is below here and is stable all the time, that's the mortality rate of people on heroin and methadone and opium, so the illicit opiates. That has been stable over time, over the past 10 years. But the prescription opiates has been stable until somewhere 2016, but then it peaked. So, you could say, somehow the increase in oxycodone use has not led to the situation in the United States, where this increase in prescription opiate use was in time perfectly paralleled by an increase in opiate mortality. That is not the case in the Netherlands, and I can share you the data of 2018. We didn't have them at the time that we published this, but the number of opiate-related mortality is going down again. So this peak has been one peak in 2017, and then it was gone again. So somehow the Dutch situation is really different from the situation in the British Isles, in Canada, and the United States. And it makes you think, why? And that has to do with differences in the healthcare system, that has to do with differences in the illegal market of opiates. In the Netherlands, we have, since a long, long time, quite good healthcare for people with opiate addiction. So methadone programs have been there for a long time. Heroin on prescription has been there for decades. So actually all opiate addicts in the Netherlands, well, not all of them, but most of them are quite well served. They are in care, we know them, and that has led to a reduction in the popularity of opiates, illegal opiates. And that means that since I think somewhere, maybe the 90s, there is a gradual decline in the number of opiate addicts in the Netherlands, and they become older and older, and there is only a small group of young people starting with opiates in the Netherlands. So I think our health system is quite well prepared to deal with people with prescription opiates and addiction to it. And that's why we don't see this increase in mortality, because we have something to offer for these patients. So I think that's important to realize. So the mortality in the Netherlands around 0.7, and if you compare it to the European Union average, that's rather low. And also if you compare that to the United States and Canada and the British Isles, that's extremely low. So taken together, marked increases in opiate use on prescription in various parts of the world. Interestingly enough, not that clear in Africa and Southeast Asia. So if there are people among you who would like to take a closer look at the Indonesian situation, be my guest, would be highly interesting. Then, of course, an important conclusion is that an increase in prescribed opiates does not necessarily lead to an increase in opiate mortality. So in some countries it does, but as I showed you in the Netherlands, it is not really the case. So we can learn of that. And a very important message is that the United States and Canada situation is not what is going to happen in all other parts of the world. Sometimes people tend to think what happens in the United States will be with us a couple of years later, but that's simply not true. And that's what we show with these data. So the United States has a unique situation where there have been pill mills, so people could get opiates easily. There has been this advertising by the pharmaceutical companies pro opiates. Well, that's not allowed in Europe, and I don't know how that is in Indonesia, but that's a completely different system. The addiction care is less well developed in the United States, and there is this insurance issue with access to healthcare. It's just some groups have excellent access to healthcare, but quite a lot of groups don't. They don't have a well-working first line, so general practitioner circuit, which is quite different in many countries in Europe. They didn't have a good monitoring system of pharmacists, which has changed now. So there are quite a lot of differences between the United States situation and elsewhere in the world. And that's why I usually say, like sometimes in the Netherlands, people say, oh, the opiates, it's a problem and we should not prescribe them anymore. But I think if you prescribe them in the right way and monitor opiate use adequately and don't prescribe them just for a 3-month recipe without any checks, opiates are excellent painkillers. But you have to be careful. That's the only thing. But that counts for so many medications. It's not that you shouldn't use it, but you should use it in the right way. And then I think that's not so much of a problem. So I was wondering, are there questions about this first part? Because the next is the psychiatric comorbidity part.
I would like to invite the participants who would like to ask questions. You can raise your hand or type your question into the chat box. Anyone? So not yet, Professor.
Okay, so then I'll continue.
Yes.
But again, so if there are people interested in looking at epidemiology in Southeast Asia, I think there are hardly any data now in the literature. So that would really be a good publication, I think. It's important. So then we move on to psychiatric comorbidity. So chronic pain, that's what we're talking about here, usually, because you have, like, if you have pain, of course, you have different types of pain. You have acute pain, you have chronic pain, and you have what is usually separated out, cancer pain. And you can imagine that in the acute pain situation, there's no discussion about prescribing opiates. If that is needed in an acute situation, please help your patient and with proper analgesia. If you have a patient with cancer pain, of course, a bit depending on the prognosis, but don't be reluctant with treating their pain. I mean, cancer pain is, depending on the perspective of the patient. In palliative care, please use opiates as per protocol, how it should be. The difficult issue is with chronic pain that is not cancer related. So chronic non-cancer pain, sometimes it is very clear where it comes from. Some abdominal issues, or maybe skeletal issues like knee issues, backache, these kind of. I mean, you know these patients with chronic pain that is not related to cancer. And the interesting or also difficult thing about that is that once you go into chronic pain, all kinds of mechanisms get into place that are not related to the original physical cause of the pain, because your brain becomes sensitized to feeling this pain. You adapt your lifestyle to dealing with that pain, and then all kinds of mechanisms develop that sort of contribute to the pain remaining in place despite the original cause of the pain not being that or being less important at the moment. So chronic pain is really a complex issue where all kinds of neuroplastical changes in the brain take place, where all kinds of psychological and social influences affect pain perception, and besides the original biological cause of the pain. And that makes chronic non-cancer pain a difficult issue to treat, because there it is not only following the pain ladder, paracetamol, NSAIDs, and then opiates. There it is very important to also look at non-pharmacological interventions. And in fact, these kind of patients have the highest risk to develop opiate use disorder, because their pain will be with them for a long time. So they then will need opiate prescriptions for a long time. And if you take opiates for a long time, you will become tolerant to these opiates. So you need more and more to get the same effect. And then there is this so-called opiate-induced hyperalgesia, where pain thresholds lower because of opiate use. And then you run into trouble, because if your pain thresholds lower, that means that you feel pain of all kinds of intensities without being a very severe physical cause. So that would require even more opiates, and then you get into a self-perpetuating cycle of increasing opiate use and increasing pain perception. And that's really a nasty development, because it's really difficult to get out of that self-perpetuating cycle. So that's the reason why I focus on chronic non-cancer pain here. So if you look at the prevalence of psychiatric conditions, major depression, anxiety disorders, post-traumatic stress disorder, and substance use disorders. You look at the general population, these are common disorders, you all know that. And if you look at the prevalence in chronic pain patients, it's impressive how much psychiatric comorbidity is there. So it's up to about 1/3 of the people with chronic pain having either major depression, anxiety disorders, and addictive disorders. And quite often, these disorders also come together. If you have major depression, maybe that goes along with PTSD or substance use disorder. So people suffer from more than one condition besides their chronic pain. And that really interferes with their quality of life. You can imagine if you have chronic pain and you also suffer from depression and an addiction, your quality of life goes down, right? So, yeah, this is an important topic to address and to be aware of. And in the literature, you will find different mechanisms that might play a role in this frequently observed comorbidity. So first, and that's what many people will tell you, yeah, when you have chronic pain, yeah, that has an impact. And chronic pain, yeah, I don't know, probably among the audience, there are people who have suffered chronic pain at some point in their lives, or maybe still up to date. Yeah, that it takes a lot of energy, chronic pain. To feel pain all day is nasty. You become tired of it. Some people even become suicidal of it. And you can, yeah, if you cannot do the things that you used to do, you can also imagine that you become more socially isolated, or you cannot work anymore, and that can make you depressed. So people become anxious for the pain because they don't know what the day will bring. And if they wake up in the morning, they are anxious that they will feel a lot of pain that day. So you can imagine all kinds of mechanisms that pain can induce psychiatric symptoms. And people maybe start drinking alcohol to have to feel less pain, or taking cannabis. There are interesting studies that cannabis is in fact also a painkiller. But yeah, when you start taking cannabis, you might also develop cannabis use disorder, cannabis addiction. So the mechanism of pain inducing psychiatric comorbidity is, I think, a logic way to go. But it could also be the other way around. It could be that people with a depression experience physical symptoms related to depression, or they experience physical symptoms more severe because of their depression. And that's why they might feel more chronic pain. So it might be that this pain is in fact part of a depression symptom, but it might also be that if you are very anxious and you feel something in your body, you tend to feel the pain more intensely than somebody without the anxiety. So in fact, psychiatric conditions may also have a causal effect on pain perception and increased levels of chronic pain. So the association with psychiatric disorders and chronic pain might go two directions. And there might even be a third option, that there is a separate factor that makes people more vulnerable for chronic pain on the one hand, but also for psychiatric conditions on the other. And you could think of, for example, early adversity, early life stress, that this regulates the stress axis, so the HPA axis or the adrenergic response. That makes you more vulnerable to develop all kinds of psychiatric conditions, including mood disorders, anxiety disorders, and addictive disorders. But such a dysregulation in the stress system also makes you more sensitive to pain and the development of chronic pain. And in fact, this is what we see in our patients. I don't know whether you regularly ask for traumatic experience in your patients with psychiatric conditions, but they report far more trauma exposure than non-psychiatric patients. And the same holds for patients with chronic pain, with or without psychiatric conditions. So this trauma exposure might be a third factor that predisposes for the development of both a psychiatric condition and a chronic pain condition. And then there are, for example, also shared genetics. So some genetic variation predisposes both to depression and chronic pain. And so this creates a very strong link between these conditions of chronic pain and psychiatric disorders, and that's why they so commonly co-occur. So taking a bit of a closer look, in the end, in your patient, it is very likely that there is a mixture of psychiatric symptoms influencing pain, pain influencing the psychiatric symptoms. There are all kinds of third factors that aggravate this relationship between these two domains. So in every patient, probably a mixture of all these mechanisms can occur. And it's up to us in the diagnostic process to disentangle all these aspects and to develop a personalized treatment plan for it. So if you look at these shared biological mechanisms more closely, and this relates to the lecture of the first day, you can see that in addiction and in other psychiatric conditions, the reward pathway is involved. Anhedonia, you see that in addictive disorders, you see that in major depression, you also see that in people with psychosis, but you also see that involvement in chronic pain. It's interesting to read the Neurobiology of Pain, and there a decrease in activation in the reward circuit has been shown, which is exactly the same as we see in our addiction literature, in the depression literature, in the psychosis literature. So this might be a shared biological mechanism between these different conditions. The same holds for dysregulation in the stress axis, as I told you just before. So we see dysregulations within the amygdala system in anxiety disorders, in mood disorders, in addictive disorders, but also in chronic pain. The amygdala is hyper-responsive. So again, this might be a shared mechanism with different, in different conditions, just leading to a different phenotype, but with the same biological mechanism underlying it. So what we also see in patients with chronic pain is quite often problems with emotion regulation and cognitive control and disturbances in memory processes. So if you take a close look at the biology literature for these different conditions, there is quite some shared mechanisms, and that is mainly if you read the literature on stress-related disorders, so disorders of negative affect, anxiety, depression, like mood disorders, PTSD, panic disorder, addiction, and pain. That is a sort of group of syndromes, of disorders that shares substantial mediating mechanisms. Is this clear enough for people?
Yes.
Because if this is true, and these different mechanisms, these different conditions share heritability, they share biological mechanisms, then of course this pleads for an integrated treatment approach. So people in chronic pain should not be only treated with and by a physician who has a lot of knowledge about pain, but also about people who have a lot of knowledge about these kind of psychological processes. And the consequence of that is that you need interdisciplinary teams. You need an interdisciplinary collaboration between psychiatrists, psychologists, internal medicine, surgeons, to be able to properly treat people with chronic pain. And that's not everywhere the case that it is organized like that. But if you take a close look at this literature, that can be the only conclusion. So as an example, in our hospital, we have now arranged it that we have a specialized pain facility. There are anesthesiologists working there. They are the pain doctors. They have psychologists, medical psychologists working there. So all patients will also be seen by a medical psychologist. If they detect psychiatric symptoms, then I will send my clinical psychologist there. And if he thinks it is needed, they will send the patient to me, and I will be involved as a psychiatrist. So we have this system of stepped care again. Like the first step is the anesthesiologist, the pain doctor, and a medical psychologist. And then from there, if we find that there is a psychiatric comorbidity, then our psychologist and the psychiatrist also become involved in a nice collaboration. And that really helps. About 5 years ago, the anesthesiology department in our hospital had the highest levels of complaints, formal complaints, and at the hospital. And that mainly was because, these chronic pain patients, they came for a treatment and they could not be cured. And then the pain doctor says, I cannot help you. So bye, good luck with it. And that was one of the reasons why they were very motivated when I came with this story, that we should collaborate. Because they felt, well, something is going wrong because we have so many formal complaints. So if you want to help with that, it's fine. And then when we started helping them with their consultations, we realized that there was not enough attention for the psychological and social aspects of chronic pain. So that's why we developed this infrastructure with an interdisciplinary approach. And as a result, we saw the number of formal complaints gradually coming down. And now they are very, very happy that we do this together, because they are also, for them, for the pain doctors, it's sometimes also difficult to fully understand the psychology of chronic pain and the relationship with psychiatric comorbidity. That's not their specialization. I mean, that I cannot ask from them that they understand all that, as well as I don't understand all the details about pain. I'm just a simple psychiatrist. So we have different specialties. But combining those forces leads to a far better treatment approach, and also patients that are more happy with the treatment that they get from our hospital. I think there's an important lesson there to don't see that a human being as like you have a head with psychology and psychiatric disorders, and you have a body that is separate with all kinds of physical conditions. I mean, it is connected. A neck is not that big, but it is connected, and it influences one another. Physical conditions influence the mind influences the body. So the best way to look at problems is an integrated view. And I'm really convinced that is the way to go to improve patient care. I wonder what you think about it. But I really try to make a strong plea for that also in the hospital, and people are open to that. If you come up with a good story and with scientific support, then people are interested in such a story and they see the results. So it's important to think about it.
It was impressive.
It
was impressive.
So I told you that stress-related disorders have a relationship with chronic pain, and so there have been several studies out there in the literature showing that people with anxiety or negative mood symptoms like depression, if they receive the same level of a pain stimulus as a control person, they feel more pain. So if you, for example, with electricity or with ice water or with pressure, you can induce pain, and you can press as long as somebody says, well, I cannot bear it anymore. And people with comorbid psychiatric conditions with negative effect, so anxiety and stress and depression, they feel more pain. So they retract their arm earlier than control persons. If you provide people with, for example, morphine, if they have a pain condition, for example, after surgery, the ones with comorbid symptoms, stress-related symptoms, they experience less analgesia with the same dose of morphine. So to get to the same level of analgesia, they need higher dosages. And also, what you see in the literature is that the duration of opiate prescriptions in patients with a certain pain conditions, for example, again, after surgery, is longer in the ones with comorbid stress-related symptoms. What you also see is that these patients experience not only the wish to use their opiate for analgesia, but they also sometimes report that they feel that these opiates make them feel less bad, which is called negative reinforcement. So they feel bad because maybe their mood condition or their anxiety symptoms, and the opiate does not only reduce the pain, but also reduces the anxiety or the depression. And then you come into another motive for taking the opiates than only analgesia. And then finally, you see that these people with comorbid stress-related symptoms report lower quality of life. And all these things together make that patients with pain and comorbid stress-related symptoms are at an increased risk to develop opiate use disorder, because they feel more pain, the opiate has less analgesia, so they take higher dosages for a longer time, and then they feel, this also relieves other kinds of bad feelings, so I want to take it, and I keep on taking it. And then in the end, this can lead to a dose escalation and long-term high-dose opiate use that can end up with overdose and addiction. So if you take that together, there is a clear association between psychiatric conditions and chronic pain, and also a long-term excessive opiate use. There is a strong call for interdisciplinary collaboration, both already in the phase of screening and diagnosis, but also in the phase of treating these patients. And if you start an opiate, it is important to monitor opiate use and monitor for psychiatric symptoms in your patient. And I can imagine in the acute situation, in case of, acute surgery, you're not going to do that. But especially if you think about a more long-term prescription of opiates because of chronic pain, it is a need. It's not just an option. It's a need to assess mental health in your patients before you start that. Because if there are mental health problems, these patients should still receive proper treatment, but maybe some more attention to the effect of the potential psychiatric comorbidity. Maybe you should treat your patient in collaboration with a psychologist or a psychiatrist to make sure that you are not going to induce yet another problem with your chronic opiate. So I think that is an interesting way of collaborating. I like it very much. So I have collaborations with the neurologist, with the anesthesiologist, with the infectiologist, with the hepatologist. And that makes my work very interesting. I like to bridge a gap between the mental and the physical part. And I experienced that my colleagues focusing like the medical specialists on whatever specialization, and that they are quite enthusiastic about such a collaboration. So that's at least an experience that I would like to share with you. So I have one more part on treatment. I was wondering if there are any questions so far.
There's no question.
No question.
Yes.
Okay. So what shall I do? Continue?
Yes.
Okay. There we go. So if you have a patient with chronic pain and an opiate use disorder, it is again important to do several things. First, it starts, like we said yesterday, with a good motivational interviewing style. Sometimes these people are really suffering because they don't know what to do. They have chronic pain, that's awful. They have opiate use, and they feel the negative consequences of their opiate use. And in fact, they quite often say, well, I want to stop, but I cannot. Because if I reduce the dose, I get severe withdrawal, my pain goes up, my depression goes up. So yeah, I don't know how to do this. So it's very important that you are non-judgmental to your patient and you collaborate with your patient in shared decision making. So MI stands for motivational interviewing and SDM stands for shared decision making. So you collaborate with your patient. Your patient is your collaborator. Not a consumer, it's a collaborator. And together you decide, okay, what can we do step by step? Should we first work maybe on your mood symptoms before we start tapering off the opiates? And if a patient is not ready, then use your motivational skills to get a patient into a next phase preparing for change. So a second issue is that what I already mentioned, beware of psychiatric comorbid symptoms in these cases with chronic pain and chronic opiate use. And that's particularly relevant because psychiatric comorbidity is associated with tapering failure. So if you start tapering without paying attention to the psychiatric comorbidity, there's a high risk that people drop out and they will not finish with your tapering process. And another aspect that if you start tapering, this might increase suicidality. So that is something to discuss with your patient before you start. You should monitor it. It's really, I've fortunately not experienced it yet, but some of my colleagues told me that they started tapering and then the patient during the process committed suicide. And that's not what you want, of course. You start tapering because you want to help a patient and you don't want to lose that patient. So talking about this from the beginning and then discuss how you can monitor suicidality, and if that comes up, that the patient is open about it. And then you can take your precautions, maybe slower your tapering or take one step back, increasing the dose a bit, or looking for psychosocial support for the patient to deal with his or her emotions. I think that's very important. Suicidality should not be ignored in these patients. They really suffer. If you have pain on a daily basis, that can really make you suffer. So then often there are physical issues in place. So sometimes physical causes of pain, but also physical comorbidities that increase the risk during detoxification. For example, you often see that when you start tapering off opiates, this has all kinds of cardiovascular effects with hypertension, tachycardia. It also dysregulates your control of the glucose, blood glucose. So patients with diabetes might run into all kinds of irregular blood glucose levels. So it's important to look at these physical comorbidities from the very beginning and pay attention to it. And again, that makes the job interesting, right? So you're not only looking at one thing, you are, as a doctor, you look at the whole picture. So that's very important. Then usually if you detoxify from opiates, that takes about 4 weeks in an inpatient setting and about 3 months when you do that in an outpatient setting. And you can taper off every 3 to 5 days. You take a dose reduction usually. So this is the basics of what you should do if you have a patient with chronic pain, long-term opiates, and you want to help them getting off the opiates. So in more detail, there have been some different protocols for tapering of opiates. So the yellow one is the most common approach. So you reduce the level of opiates between 5 to 20% per week, per 4 weeks. And taper, you can pause it if a patient says it's too fast. You can sometimes increase the speed if a patient says, well, I can go faster. So this is a sort of a range, and you can see that then it takes a couple of months before you fully tapered off the opiates. So there are cases where you can go faster. And I would recommend an inpatient setting if you want to go faster, because then opiates, the opiate withdrawal can be rather severe. So you want to monitor that strictly. So then that's easier if you have a patient admitted to your ward. And then you can go up to 20% of the dose reduction by week, or sometimes even faster, up to 25 or 50% of the dose reduction. But that is really going to induce severe withdrawal. So if you do that, always think about supporting medication like clonidine or loperamide to treat symptoms of withdrawal and to make sure that the patient will be able to successfully finish the tapering. In some cases, you might also consider a slower tapering. When there is severe psychiatric comorbidity, when there is severe physical comorbidity, which makes tapering dangerous, then please go slow. Prepare your patient for that. Sometimes patients think, well, I can do this in a couple of weeks, but explain to them that tapering of opiates is not just a simple thing. And there might be reasons to go slow. And sometimes I work with patients for over a year and really step by step slowly taper off. And then it can still be successful. But if you would go faster, then you lose your patient. So sometimes, and that's the clinical judgment. There are no clear rules that can say, okay, this patient, that speed, that patient, that speed. That's really something like a clinical judgment in close collaboration with your patient in shared decision making. Come up with a treatment plan which includes the speed of tapering of your opiate. So we did a study in the Netherlands, and I'm sorry for the Dutch language here and there, but this is the title of the study. So for some patients, this tapering simply doesn't work. They want to get off their opiates, but they fail because they feel too much pain, they feel too much withdrawal, their depression and suicidality comes up, and then you can just not continue. And then you're stuck. So what to do then? Of course, you can do non-pharmacological treatment, very important. Of course, you can take your time and maybe try again a year later. It's also fine. But we thought, well, maybe there are other opportunities. So one thing we thought of is switching these people to Suboxone, so to buprenorphine. which is a partial opiate agonist. And the idea behind it is that buprenorphine might lower the opiate-induced hyperalgesia. And from addiction care, we know that Suboxone tapering is easier than tapering with full agonists. The only thing that has not really been described in the literature for patients with opiate use disorder and chronic pain. So we started off with a clinical trial, open label, measuring people closely, then switching them to Suboxone during a 10-day admission in our psychiatric ward, and then a 12-month follow-up. And I will not share the details of the study, but go directly with the results because that is the most important maybe, and also quite impressive. So what you can see here is the subjective level of pain, the visual analog scale. So just on a scale of 1 to 10, ask the level of pain, of 1 to 100, sorry. So 100 is the maximum score. On entrance, these patients on average scored a 50. After the rotation, they had lower self-reported pain, which was an improvement that I did not expect. I had hoped that the pain would remain the same and not worse, because some studies suggest that the partial agonist has less analgesic properties than full opiate agonists. So yeah, if that were true, then there might have been a risk of increased pain, which was clearly not the case. So these people improved in terms of pain. But look what happened with their craving for opiates. A dramatic improvement. It was almost gone, which is really nice because these people were craving for these opiates. They needed them. They really wanted them. And after the rotation, they said, well, I'll take them, but and that makes it easier to taper off the Suboxone. Look at the symptoms of depression, anxiety, and stress. They were quite high at baseline, but they diminished almost by half after the rotation. This is an impressive improvement. And then the last one is opiate misuse levels. And this questionnaire has a different scale. The maximum score is around 30 something. So they had quite high misuse scores at baseline. And that also diminished impressively after the rotation. So we have a very successful rotation here.
Perkumpulan hati.
Oh, somebody's going home. So I think, I was impressed by these data, and I can share you a story of one single case, a woman that was in hospital for months on different departments because she was injecting pethidine into a portacut herself because of chronic abdominal pain. And she had all kinds of complications because of this injecting in the portacut, because it led to infections. She had a cardiac thrombus. So she has been in the hospital for months on all different departments because of the abdominal pain, and then to cardiology because of the cardiac thrombus on the intensive care, and then to infectiology because of the infection, the cardiac infection. So she had been in hospital for months, and the situation was only getting worse. And then they also run into difficulties in the communication with that patient. So they asked the consultation of the psychiatry department. And my colleague went there and he said, Arnt, you know something about opiates. What do you think? So I also saw that patient. We took the patient to the psychiatric department, and she couldn't take oral medication because of the abdominal issues. Injecting, I think, was not really an option. So Suboxone is a sublingual tablet, which has so you do not have to swallow it, so you're not dependent on the stomach and the abdominal situation. So we switched this woman to Suboxone, and this is a success story, of course, otherwise I wouldn't tell it. But 1 year after this rotation, this woman that was diagnosed with borderline personality disorder did not fulfill any of the criteria anymore. She was stable again, and she got back to her work as a manager again. She had been jobless for years because of this whole situation. The psychiatric symptoms in terms of mood and anxiety were gone. Her suicidality was gone. And this is, of course, a success story. There are also other stories. But it shows that it is really important, again, to collaborate between the mental and the physical specialists. So maybe go to the conclusion, also because it's already 8:45 here in the Netherlands. What I told you today is a bit about the epidemiology of opiate use across the globe, and that there is an increase in opiate prescription in many places in the world, but that the situation is very different between countries, and that increase in opiate prescriptions not always leads to an increase in opiate mortality. So we should not only be afraid of opiates, and then because they are excellent painkillers, then the interesting relationship between psychiatric symptoms, chronic pain, and opiate use, how that sort of can influence each other, and that also calls for interdisciplinary collaboration between pain specialists and mental health specialists. And then I finally showed you some data of our own study on Suboxone, so the combination of buprenorphine and naloxone, in patients with really high dosages of opiate use and severe opiate use disorder and chronic pain, showing clear beneficial effects on subjective pain, but also on psychiatric symptom levels and also on opiate misuse. So maybe this is the last slide of today's lecture, and I'm of course open for your questions.
Thank you, Prof. Arnt. You also had told the conclusion. Thank you.
Okay.
And there's a question from Dr. Florentina Reddy. She asks, have you ever had a psychiatric case, especially in addiction, which was difficult or did not heal despite many interventions? I think you have told one story.
Yeah, well, not all cases are successful, of course. And for example, in this study with this Suboxone rotation, we saw that 10% of the patients did not improve. And in fact, they wanted to go back to their opiates. And that's 10%. So that's quite a substantial proportion. It's not the majority, luckily, but it's still a substantial proportion. So for those patients, we rotated them back to a full agonist. And the main thing is then that we chose a full opiate agonist with long-acting, so either long-acting oxycodone or methadone, and that also already stabilizes the pain and mood symptoms a bit. And usually what you see is after a rotation that you can give a lower dose than the original dose. And from there you can then take the next steps in looking for other ways of supporting that patient, even though your rotation to Suboxone failed. So this success is not always there, and that's obvious. And sometimes it can be difficult because sometimes withdrawal is very, very severe. And then, it requires a lot from your patient, from your team, but also from your own skills to keep your patient motivated to continue and support both in a psychological way and with the proper medication. Um, so yeah, that's the reality. Um, but yeah, I mean that you have that in any condition. So if you are work with in oncology, you also lose patients. If you work as a cardiologist, yeah, not all your treatments are success stories, and that's not different in psychiatry. I mean, yeah, I also have some chronic cases that do not improve. Yeah, true. And some people die. So I told you in the very first day that addiction and eating disorders are the psychiatric conditions with the highest mortality rates. Yeah, I also lost some cases, either due to physical complications of the psychiatric conditions or because of suicide. Yeah, that makes you sad, but that's unfortunately part of being a doctor, that you also have to face suffering, human suffering, and sometimes death.
All right, thank you, Professor Arnt. And maybe Dr. Eva would like to ask a question.
Thank you, Prof. Arnt, for your lecture. I would like to ask you about your opinion about the CBD oil. I have patient ask me about do you give the CBD oil if the patient asks you to treat the chronic pain or anxiety and also sleep problems? Thank you.
Yeah, that's an interesting one. So, yeah, indeed, there is some evidence, as I told you, that cannabis and cannabinoids have analgesic properties, and yeah, so I can imagine that people ask for it. The main issue is that we don't really have strong evidence, like what kind of dose, what kind of cannabinoids work best. And in fact, we are now doing a trial together with Leiden University, so another university in the Netherlands, in the western part, where we combine opiates with cannabinoids, hoping that we can reduce the number of or the level of opiates that people require after surgery. And then I think those kind of studies are needed to get to real evidence for providing cannabis or cannabinoids to our patients. Because all these kind of cannabinoid oils and tea, or I mean, if you go out there in the shops, you find you can get everything made from cannabinoids. there's tea, there's cookies, there's oil, there's whatever, there's everything. And in fact, we do not really know what is in there, how much is in there, what is the effective dose, what are the risk and adverse effects. And as long as that is not clear, I usually stay a bit away from prescribing it. And if people decide to do that on their own, I mean, I cannot prevent them from doing it. What I do want them is to be transparent about it. So I do want to know about it. I won't judge about it, but it is important to know that they are experimenting with it, because it might also influence other treatments. So that's what I usually explain a bit to my patients, that there is this idea that cannabinoids might be effective, but there is not just enough evidence to really know what we are doing and what kind of dose we should give and so forth. And that is why I will not prescribe it. So it's just an exciting area of research. And yeah, that maybe in 5 years' time we know more about it, and maybe then I would give a different answer. So I would then say, well, there are nice studies showing that this cannabinoid in this dose is highly effective in reducing pain, and it's safe to prescribe. Yeah, then that's how science works. You start somewhere with some observations, and then try to develop the evidence in order to be able to advise your patients based on the proper scientific evidence that there is. So that would be my answer. It's not a full advice.
Okay, thank you so much, Prof. Arun.
Yes, this is also, there's a question from Dr. Felicia Saraswati. She asks, in patient with chronic non-cancer pain who develops psychiatric symptoms such as depression and anxiety, do you still consider giving antidepressant or anxiolytics, or is managing pain and giving psychosocial support?
Yeah, also a nice question, and I think a very relevant one because of the frequency that this goes together. And there are some antidepressants with analgesic properties. So, like we discussed yesterday, comorbidities might guide you in the choice for your antidepressant. For example, duloxetine, I don't know whether that is available in Indonesia, but duloxetine has in several studies been shown to have good effects in patients with chronic pain. I also have that experience that in some patients providing duloxetine was effective in both reducing the depression and the pain. And after that treatment, we could taper off the opiates. So if you have somebody without opiates, but chronic pain and mood disorder, you could think of starting duloxetine to take both conditions, to target both conditions. Amitriptyline is similar. There is a good indication for amitriptyline and to a lesser extent also for other tricyclics for neuropathic pain. So if you have a patient combine depression and neuropathic pain, yeah, it makes sense to think about starting amitriptyline right away instead of first trying opiates or maybe citalopram. Yeah, of course, depending on the safety profile in that particular patient, because if you have a patient with cardiovascular disease, these tricyclics might be dangerous. But still, yeah, these are considerations that you should have, and again, that's personalized medicine. That's thinking, but not just following the protocol, but thinking, what is my patient? Look at the whole picture, and then give a wise, evidence-based advice for that specific patient.
Thank you, Professor. And this is maybe we'll go back to the first lecture, your first lecture. It's about Marshmallow Experiment. So from Marshmallow Experiment.
Oh, yeah.
That you said before. And this is from Dr. Florentina also. I heard from Prof. Arnt about midbrain controlling for children. Could you explain about midbrain controlling? Can this treatment be used to adults? If yes, will it give the same effect when given to children?
So yeah, in this Marshmallow Experiment, we saw that the approach tendencies of these kids were sort of mixed with avoidance tendencies, like they have approach and control behavior within that video, right? And my message was that in these experiments done in the 70s, in the follow-up, they saw that these kids that had problems with controlling themselves, or well, problems, they just took a marshmallow. That's not really problematic, but they were they were just more prone to take it, and they could not control themselves as good as the other kids could. So those kids had higher risks in later in life for financial problems and divorce and, well, drug addiction and so forth. And then in the United States, they developed these programs to help parents raise their children. And I can imagine that you think, well, if that works with children, why not in adults? Yeah, and in fact, I think that the community reinforcement approach that I told you about taps into that same mechanism. This Marshmallow Experiment, you could also do that in adults, but then you shouldn't use marshmallows. We used it also in Indonesia, in the HIV population in Bandung, using delayed discounting task. And what you simply do in a delayed discounting task is asking, okay, you can get 1,000 rupiah now, or I give you 5,000 tomorrow. You can choose 1,000 rupiah now, 5,000 tomorrow. And then you can take two directions. One is you play with the delay. So you can say, well, maybe not tomorrow, but in 2 days' time, or a week, or a month. And yeah, people will not wait for 4,000 extra rupiah for a month, but others will. So you see these differences, right? The other thing you can play with is the amount of money. So you can say, okay, well, maybe you are not willing to wait 1 month for 5,000 rupiah instead of 1,000. But what if I give you 100,000 rupiah instead of 1,000? Will you then wait a month? So you can also play with the amount. And what you then get is a curve of devaluation of the reward, in this case money, based on the delay. And people who are more impulsive, also adults, will have a steep discounting curve. So they don't accept the delay. The delay aversion is very high. And you see that in all kinds of impulsivity studies. In ADHD, you see that delay aversion. You see that in people with risky behaviors, in the HIV population. Some studies even show that males have more delay aversion than females, which is interesting. Yeah, this is also a kind of a trait. So it's not easy to change that. But what you could do is, by cognitive behavioral therapy and by a community reinforcement approach, making people more aware of this process going on. And you can then help them think about the difference between short-term reward versus long-term rewards. And sometimes these people are completely driven by short-term rewards that on the long term are disadvantageous for them. And sometimes they don't realize that. So in your cognitive behavioral therapy, or in your community reinforcement approach therapy, or in your motivational interviewing therapy, you can help your patient to shift the attention from the short-term reward towards the long-term rewards. And that's not easy. That will not go by itself, but you can train people in balancing their lives. We all need short-term rewards, of course. Nobody will say, well, I don't need any short-term rewards. We want a nice social interaction. We want a nice cup of coffee. We want whatever. But yeah, to be able to lead a healthy and happy life in the long term, sometimes you need to withhold yourself in the short term. And that's precisely what you can train with your patients. So it's well possible. That's basically psychotherapy.
It's interesting, Professor. I want to know what do you think about fasting?
About?
Fasting.
Fasting.
Yes.
Fasting, yeah, that's a different topic. I've never studied fasting.
Because, yeah, from your, what you say that it's like maybe mind controlling, right? So to delay the gratification to
Yeah.
yes.
I can imagine that is a way of training the same principle. Yeah. And you will, yeah, maybe it's not easy to talk about it, but there are most probably there are difference in people who are able to complete the fasting month, and for others it is easier. And yeah, that's interesting. So there are just differences between people. I don't know. I don't know about studies on this topic, but it would be interesting to take a look at that literature. Yeah.
Thank you, Professor. And anyone who want to ask to the professor? We still have maybe 10 minutes, or we can just close this session. Anyone? Okay. Yeah, maybe that's all, Professor Arnt.
Okay.
Thank you. Yes, thank you for a very interesting lecture and also an interesting discussion in these 3 days. Thank you very much.
Thank you for the invitation. It's nice to do this, even though it's even nicer if we would have a real life contact, of course. I hope people enjoyed it and maybe even learned a bit of it. Yeah, I also hope that this contributes these kind of exchange to improve care for our patients, because that's the end goal. I mean, it's nice to talk together and to exchange ideas, but we have become professionals to help patients, and I hope exchange like this can contribute to that. And if that is the case, even only for one patient, I'm already happy.
Yep. Thank you, Professor Arnt. And maybe after this, I would like to turn the mic to Dr. Evelyn.
Thank you, Dr. Dorothy Klima and Prof. Arnt. Okay, today is the last day of our online seminar series. To end this program, we are pleased to have Dr. Eva Suryani as a committee chairman of this seminar, and also as a psychiatrist and lecturer of psychiatry and human behavior in Atmajaya, to deliver the closing remarks. Please, Dr. Eva Suryani.
Okay, thank you, Dr. Evelyn. Dear colleague, I believe that all of you have well done through the 3 days online seminar series. It is my great pleasure that you had a fruitful discussion through, I think 3 days is not enough. Since the year 2000s, the number of drug users in Indonesia, both injecting and non-injecting, was estimated to be among 1.5 millions and are predicted to keep rising. Understanding the neural mechanism involved the comorbidity is crucial to finding a comprehensive treatment. A range of care with a tailored treatment program and follow-up option can be crucial to success. I hope that you have learned through the topic will help you a lot in your role as a GP and health worker in the future. I also want to thank Prof. Dr. Arnt Schellekens, PhD, for taking time out of your busy day to share your experience with us for the past 3 days. The information you share was very enlightening. We hope it was a positive experience for you as well. We also to apologize for any problem or inconvenience during this online seminar. As a continuing topic of this seminar, we will have another online seminar on 26 November 2020 about treatment and rehabilitation approach for addiction with Janika Hetman, PhD, a psychologist of University of Groningen, as a guest speaker. Further information will be announced through media social and our Instagram at addictionstalks.id. And finally, I would like to close my remark and officially announce the end of this online seminar series. Thank you also for Dr. Durotul and Dr. Evelyn and Mas Yosef, who helped me so much in this online seminar. And also thank you for all participants. Like Prof. Arnt said, that after this seminar, we hope we can improve our knowledge and also improve care to our patient. Thank you so much. I give it to Dr. Evelyn again. Thank you.
Thank you, Dr. Eva, for the wonderful closing remarks. Finally, we come to the end of this event. And thank you once again. Thank you very much for your participation in this session. I hope you enjoy this program and also all of the online seminar series. Okay, I will inform you the last information. Maybe before that, I suggest to all the audience to turn on your camera because we will take our photo together as a documentation after I read this last information. For the post-test link will be copied on the chat room, and we will wait for 2 until 3 minutes before this program ends. And e-certificates are only given to participants who have failed the registration and pre-test before each session, and also post-test with past limit value 80, and can be repeated if you haven't reached the past limit value. And the post-test link will be closed at midnight, 12 a.m. West Indonesian time on each day. And also, Mas Yosef, can you show the slide presentation? Okay, for as a continuing the seminar series, don't forget to join our second seminar series as a guest Janika Hetman, PhD, and our guest speaker. She's a psychologist and researcher, and the topic will be cognitive behavioral therapy for substance use and gambling. It will be held on November 26, 2020 at 2 p.m. Jakarta time, and for further information, it will be announced through media social and our Instagram. So once again, thank you, Prof. Arnt, Dr. Eva Suryani, psychiatrists, colleagues for attending this lecture. Now it's time for us to take our photo together before we end this video meeting. Okay, 1, 2, 3. Okay, thank you.
Thank you, Prof. Arnt.
Thank you so much, Eva.
Yeah, thank you so much. And Isadora send you regards also for you. And
Wonderful.
hope, yeah, we can meet you.
Yeah, send my regards back, right?
Okay, thank you so much.
Okay.
Thank
Yeah,
you.
bye-bye.
Bye-bye.
Bye. Yes. Okay, I will end call.